And what you're seeing here is what I call, this is basically my understanding of the supply chain. And it's just ranges from production to consumption. Now, in the context of the private sector, I would say there's something missing. And I'd like you to help me place it. And that is called demand. And in this chain, demand can either be at the beginning, before production, or at the end, after production. Because the supply chain in the private sector view is all about efficiencies leading to the best cost at the end of the chain. So I, as a healthcare financier, will be seeking to procure healthcare at the best prices. And that means that there has been efficiencies in the health supply chain that enables delivery of either pharma, pharmaceuticals, commodities, or services to my client at the best possible price. So we see our role in healthcare financing as being one that ensures that after all the professionals in this room have done their thing and the medication has reached the point of service provision, that there is somebody to buy it. Now that's where we differ slightly with the government, where you're supplying county governments or you're supplying the central government who has paid, and it's all about you getting it to the hospitals and the public will come and consume it. Our public, the private sector public, comes to consume it and pays, and therefore seeks the best possible pricing. So we see demand as a supply chain link. And for healthcare providers, we're told the supply chain is second only to staff as a cost of business expense. That being the case, it is therefore our considered view the supply chain has the most profound effect on healthcare costs, which are important to us as payers, as healthcare financiers. And therefore, efficient supply chains can reduce the overall cost of care. And that impacts our financing models, because we do have financing models for this. I'll give you an example. If you go to buy health insurance, the cost of the services and medication and everything else involved will affect what you will pay in terms of an insurance premium. Now we at Changamka deal mainly with lower income populations. And I can tell you that the difference between buying insurance for the lower income populations is the difference between 500 shillings and 450. It is that critical. That if it's 450, they may buy it, but at 500 shillings, they will not buy it. Therefore, efficiencies that you are able to drive through the supply chain are absolutely critical to whether we will be able to deliver to the lower income populations. So what have we done on the demand side in terms of healthcare innovations? There are certain drivers that we've implemented to try and reduce the cost to the consumer of healthcare through healthcare financing. So for example, insurance, the costs are being driven, have traditionally been driven by high costs of sales. They've been driven by high service prices. They've been driven by poor access to healthcare financing. So in the last 5 years or so, particularly in this country, there has been a lot of healthcare innovations to try and drive down the costs. So you will find that you'll be able to see things like an online payer provider health data exchange, that, for example, that Changamka runs. And this does several things. It enables, for example, mobile phone registration of members. So So members are able to register where they're sitting on their mobile phone. Members can query their care usage. So you can call up your account and see the pattern of usage. How many members in your family, for example, have attended the hospital? It also allows service provision by a medical provider through a web browser. So you don't have to go and install anything in a hospital. All you do is give them a login into the system. Also enables mobile money payments. That's pretty common now. We pay for just about everything using mobile money. It allows for member administration. So for example, if there's an insurance company involved, they're able to register their members and administer it on the platform. It also is integrated to an SMS gateway, so it can give you information as to when your policy is due next month. It will also allow for medical providers, medical facilities, for their bills to be paid by the payer, in this case the insurance company, online. It has MIS reporting, and very, very critically, data analytics is a possibility with systems of this nature.
So we're saying that we moved away from doing things manually and moved them all online onto a platform that enables you to reduce the cost of administration by anything in the order of 15 to 30% or more. So the sort of milestones that have been achieved in innovation in healthcare financing is that health insurance was not available for low-income populations outside of the NHIF. If you look back 5 years ago, you either bought insurance at the NHIF or you didn't have insurance if you couldn't afford anything above 15,000 shillings. So health insurance was available, but it was only available for the higher income populations. So in 2014, a consortium comprising Safaricom, Britam, and Changamka were able to deliver a family product that offered in and out patients at 12,000 shillings per annum per family for a consolidated amount of 250,000 bob. Now that was unprecedented. And cover will now be available from 2015. You will now be able to get, 2016, you'll now be able to get cover on your phone for various medical conditions. Now that's the sort of innovation that's going on. We do believe that there's a worldwide innovation, but in particular, with particular respect to Kenya, there has been a very, very good demand creation using, how have these innovations helped push forward health financing? And so we've been able to look at demand creation using health finance data. Now data is available from these platforms that was in the past not available. It is also, we believe, possible for the supply chain to improve efficiencies by supplying medical facilities on the basis of data collected through our platforms. So in the private sector, if we have Metropolitan Hospital, for example, they are able to determine that last year from the healthcare financiers comprising insurance companies and others, they were paid so much. And they can also see from the platform what, in general terms, were the drugs that were utilized. So they can forecast for this year what the private sector is going to pay them and what will be needed. It also gives a greater understanding of the demand patterns between insured and uninsured population. So the uninsured population in this respect, we're talking about consumption by the public from public institutions, and the insured sector is everybody else, and we're then able to compare. There's quite a bit of statistics from the public sector, but there has been a dearth of data from the insured sector. So now that we are implementing these platforms, they will enable us to provide data pretty much in the same manner as the uninsured public sector. So we also look at how the supply chain, I think this is something that I've already mentioned, We look at how the supply chain can impact the cost of insurance. That is critical for the operations. So that's how we intend to integrate demand into the supply chain, because the two really ought to complement each other. Thank you very much. I hope you're able to digest your food. I'll be happy to take some questions.